Good evening, everyone. Welcome to tonight's webinar, where we're going to go through some high-yield pharmacology related to neurologic disorders for USMLE exams, predominantly step 1 and step 2, and then COMLEX exams. My name is Michael. I am a second-year neurology resident, and I am very, very happy to be accompanied today by Daniel, and I'll let him introduce himself.
Hi, everyone. I'm Daniel. I'm a third-year MD student with SEBA, practicing in Brookdale Hospital in Brooklyn, New York, and excited to be here.
So I will go over kind of briefly, and I'll have Daniel jump in as well, who we are at Blueprint Med School Tutors, and kind of everything that we do for students and all the things that we hope to do for all of you that are joining us today. We do one-on-one tutoring for people who need support, coaching, question-based strategy. That's one of my favorite parts about working for this company. We do things like this where we try and distill really big topics to a larger number of people. Blueprint also has sort of tons and tons of resources available if you're a more self-directed learner, in things like Crime Fighters and QBanks. So the whole company is sort of behind you when you work with us. We have lots and lots of years of student success. And then hopefully you see from me and Daniel today, really what we all have in common is that we really enjoy teaching and want this process to be easier for all of you. Daniel, anything to add there?
Yeah, so I've been one-on-one tutoring for a while. I really enjoy it. And with different tutors, you can get a different range of interaction. So part of it is just like you said, doing practice questions, test-taking strategy. Part of it is kind of like learning how to be an efficient, wholesome student in a way, like a more biopsychosocial approach to learning. And that's what I really enjoy working on with my tutees. So you can get a whole range of different people to work with you here. So.
Okay, so big menu of things to cover tonight. I know oftentimes not my students' favorite things. Neurology is usually not anyone's favorite. It's my favorite, and then particularly pharmacology tends to haunt people. So I'm going to walk through my approach to seizure meds, Parkinson's meds, and headache meds, sort of the big three classes. Sprinkle in some other diseases and disorders. Daniel's going to talk to us a lot about hypnotics, sedatives, management of pain, and then we'll have time at the end for Q&A. I'm going to ask a lot of everyone to participate in the chat, and then you'll also have time at the end to ask questions. I will preempt some of the questions that we commonly get in these webinars. Yes, this is being recorded. Yes, segments of it will be posted on YouTube afterwards. Okay, huge list of drugs and lots of things to memorize. So I want to help you focus your attention, right? Your job is not to know every single word of every fact in first aid. I think that that's too much to ask of yourself. So for these drug classes, I like to tell students for seizures, I want you to focus on the adverse events and the adverse effects of the meds. A little more than the mechanism, right? Because a lot of them we don't know how they work. So it's not fair for us to ask you. Sometimes you'll get tested on it, but most times not. And then more so than the indication. I would not worry as much about knowing, oh, this person has focal epilepsy. Which medicine do I use for that? For Parkinson's meds, we're going to focus on the mechanism, more so than the adverse events, and a little more so than the indication, because that is just always Parkinson's. Yes, there's some changes for tremor predominant disease, but leave that to the neurologist. You're a med student, and that's not for you. And then for headache meds, this comes up more in step 2 than it does for step 1. But we care about what type of headache it is, and then does the patient have any contraindications to the medicines we want to use? And then what I'm going to say time and time again is you make your life so much easier by having a good understanding of physiology. You don't have to memorize side effects. You can just be like, oh, this drug does something to acetylcholine. I should know what that's going to do in the body. I'll start with seizures. And I'll start with just the general overview principle of managing a seizure. Right? And I have some on here, but if someone is seizing right in front of you, there's really only one type of medicine that I want you to give them, and that is a benzodiazepine. The exception to that is if they're an infant, I would choose a barbiturate. And does anyone feel comfortable putting in the chat which barbiturate is the first line drug of choice for seizures in an infant? So I see diazepam, which is a good, and when I say infant, I will clarify, like newborn, like we're in the neonatal nursery. Diazepam is a great benzodiazepine, not a barbiturate, can be used rectally, which helps in children, but you don't have to know that. Yeah, awesome. Phenobarb. So yeah, phenobarbital is the first line drug for seizures in, when I say infants, sort of the 1 month, 3 month old type question that you're going to get. If someone has seizures and you're trying to prevent them from having seizures in the future, you have a whole host of medicines to choose from. And we choose those usually based on epilepsy type. And so there's a few epilepsy types that I'll teach you about tonight and which meds you choose for those. But more often than not, it's going to be the side effect profile. And the most common ones that we'll talk about, so we'll talk about levetiracetam, phenytoin, topiramate, valproic acid, carbamazepine, a few others. Daniel, when you are rotating on the wards as a third year, which seizure med do you see most frequently?
Definitely levetiracetam, Keppra.
Yeah, Keppra for sure.
Most often, yes.
Really, really commonly used. And then you'll hear, I think, always think like the Hermione Granger thing, right? Is it levetiracetam or is it levetiracetam? People will say either or.
I always tell people when I get a dog, I'm going to name it Keppra. That's what I tell them. Yeah.
It's one of those.
I was wondering with benzos, does anyone know what receptor they work on and which ion channel they open? If you could put it in the chat. Yeah, good. It's the GABA receptor, right? And we have lots of medicines that work on the GABA receptor. And what ion channel might it open in the neuron? Good. So, and then further question: what is the resting membrane potential around of a neuron when it's just hanging out, not firing? Good. And now, further question: is chloride more predominant within or outside of the cell? Good. So if you open up that channel, right, you allow more of a negative influx into the cell and it decreases the resting membrane potential. So then it can't spike positive to fire, right? So it kind of stops the nerve from firing. So if you have a seizure where all of these neurons in the brain are all firing all at once, right? You open up those chloride channels through the GABA receptors and then it tamps everything down. Okay?
Great. Things that also pop up that some of you may have taken questions on or will see. Benzodiazepines and barbiturates both act on that same GABA receptor, right? So the GABA A receptor predominantly. And one of them increases the frequency at which that channel opens, and then one of them increases the duration of that channel opening. And that actually matters a little bit for side effects and for toxicity. So which one affects the frequency of channel opening? Perfect, Elizabeth, benzo, everyone, yeah, Auburn, Keisha, everyone, great. So benzos increase the frequency, and then barbiturates increase the duration. Barbiturates are a little more sedative for that reason. And then Daniel highlighted a lot of the really important sort of baseline physiology that drives how these medicines stop neuronal firing in the moment.
Sorry, I was going to say barbiturates work on the duration. That's what we were always taught. Because it is a A-B kind of flipping around duration or frequency. Barbiturates increase the duration. So,
I will try and drop, I think mnemonics like that are super helpful. I always like to tell people, I'm like, if you have a really good understanding of one, then the other one is just the other one, right? So if you're struggling to remember which is which, just like commit one of them to memory, and then you just trust yourself so much that the other drug is the other drug. Again, these agents, lots of them act on sodium channels. Some of them have GABA properties. I don't think it's particularly important, and I don't think it's really helpful from a test taking standpoint. I think you get your majority of the points by knowing these side effects that I'm going to go over. Carbamazepine, right? So sort of the most common side effects, like 50 to 80% of patients will have some sort of diplopia and ataxia. And so remembering ataxia is sort of the inability to smoothly move towards a target. And then this drug can also cause hyponatremia by inducing SIADH. Rarely, but sort of a feared complication would be agranulocytosis. There's also like liver things and all this stuff. What other drug that's in the neuropsychiatric realm can cause a fatal agranulocytosis? Not covering it in this lecture. Wonderful, everyone. Yeah, clozapine. All right, you all know your pharmacology. So yeah, I think those two meds are the ones that I see that question based on most commonly. And then when I talk about CYP induction, I think it gets kind of a little bit of a head turn to which ones induce, which ones inhibit. And I think really that the way that I sort of want you all to think about these meds is they don't play nicely with other meds, right? So just the ones that I mentioned, CYP interactions, are just not great in someone who's on a lot of other meds. Lamotrigine really has a really limited side effect profile, but sort of one thing to fear, right? And that's the development of SJS, or Stevens-Johnson syndrome. I'll ask people just to keep the questions in the chat and let you all show off. If Stevens-Johnson syndrome involves more than 30% of the body, what do we call it? I know I said I'm a neurologist, but we got some derm action going tonight. Good, yeah, so TEN, so toxic epidermal necrolysis. So when you take step 2, I think it matters more to classify, but SJS is usually 10% or less of the body surface. 10 to 30, we call it SJS TEN overlap, and then TEN is greater than 30%. Lots of seizure meds. Again, carbamazepine has a Stevens-Johnson risk, but the one you're going to get asked about the most is lamotrigine. That's the highest one. Levetiracetam or Keppra, super commonly used. Often can cause behavioral disturbances. That's sort of its only side effect. Really has wonderful, like a very clean, if you will, drug-drug interaction profile. So that's why it's used in the hospital. Topiramate. This medicine, when I tell it to people, I say it's going to make you have word finding difficulties, right? So I think brain fog is something I would think about. It has a side effect of weight loss. So for some patients, it's desirable. For some patients, it's not. And you have to screen patients to see if they have a history of kidney stones. So those are the 3 big side effects. Yes, there are others for topiramate. It can cause paresthesias in the limbs and some other things, but those are the 3 that I would expect you to see the most. So if you're triaging your attention, focus on those. Sort of the opposite of that would be valproic acid, which I think causes weight gain, right, in pancreatitis. So I tend to think that it doesn't do great things for the abdomen, right? So it increases LFTs, weight gain, pancreatitis. It is sort of the classic teratogenic agent. And what sort of congenital abnormalities might I expect in someone who's on valproic acid and is of childbearing age? So Iris, I see Epstein's, which is a good thought. Limb deformities. I'm gonna search for a couple more teratogenic effects and then we'll sift through. Daniel, do you have any thoughts on teratogenicity of valproic acid?
I do not, actually. No, my thought was limb deformities.
Yeah, so I tend to think of it as one of the ones that causes neural tube defects. So sort of along with most of the seizure meds, I think neural tube defects. I think probably all of these are possible. If I'm going to sort of match each of those to one drug for step 1, Epstein's anomaly, I tend to think of lithium, maternal lithium use, so sort of the hypoplastic RV. Limb deformities, I think, are going to be associated with you all for thalidomide, which is an agent that was used in the 70s and then discontinued. And then now today is used for some cases of myeloma. And then, yeah, but I think in general, when you think about seizure med teratogenicity, I think it's safe to think about neural tube defects, but everyone provided a really great list. Okay, those are the big ones. Yes, there are going to be others in the table, like there's tiagabine and gabapentin and vigabatrin. There's also medicines that you're going to see used clinically, like zonisamide, that I don't think has made it into the testing world, right? So I want you to focus on these, and I think your goal should be to know sort of the main 80 to 90% of things you're going to be asked, and these are going to be those drugs. The one sort of special epilepsy type that I think you need to know additional meds for would be absence seizures. Can someone maybe briefly in the chat sort of just type in like the 5 words of what an absence seizure, what does that make you think of? Sort of has a very classic presentation. I think often seizures, we think about shaking limbs or eye deviation. Yeah, so Kim gave me 1 word, and I think, or Caitlin gave me 2 words, right? Stare and blank stare, I totally agree. Auburn, perfect, no postictal period. So sort of the classic description is a school-age child who has these episodes during class where they just stare up into space. They don't remember anything that happened during those episodes. They look like they're daydreaming, awesome, Elizabeth. And then ethosuximide is the drug of choice. I put an asterisk there. That is the one that they sometimes ask about mechanism. They, for some reason, like you to know that that affects T-type calcium channels. And then just for when you take step 2 and beyond, valproic acid can also be used for absence seizures. Infantile spasms is a disorder that I do not expect to show up on step 1, but can be part of the tuberous sclerosis complex. And then on step 2, and for your PEDS rotations and then your neuroshelf, you do have to know sort of the drugs that are used to indicate to treat infantile spasms. So the one that makes very little sense to me in the overall context would be ACTH and steroids. And then of the seizure meds, vigabatrin is the one of choice. You can use others, but those are the big ones. Some of the seizure types will tell you that, oh, if there's myoclonus, you should use this, this, and this. I wouldn't worry so much about sorting all that. All right, that was a whole lot. Any questions in the chat? Daniel, any questions about seizure meds? I think there's I could talk about this for an hour all by itself, but.
Well, I know we mentioned with carbamazepine that we have hyponatremia as one of the side effects. I was wondering if anyone knew what the mechanism of that hyponatremia is. There we go. Good. Yeah, so it's SIADH, so too much antidiuretic hormone, all this absence seizure knowledge.
Everyone.
Yeah. Great. So yeah, SIADH, so too much free water retention dilutes out the sodium, right?
Great. Okay. Okay. I notably skipped phenytoin. Phenytoin gets its own slide for its side effect profile. The one that you're going to be tested on the most is the gingival hyperplasia. That's sort of the classic buzzwordy, and you can see here I have overgrowth of the gums. This can be painful. Sometimes people need surgery for this. This is definitely a side effect that you should think about, and about 50% of people who use phenytoin long-term get this. Phenytoin does not play nicely with others, has lots of CYP and drug-drug interactions. Phenytoin does not play nicely with patients. It has a very narrow therapeutic window, so it's pretty easy to get phenytoin toxicity. There's lots of things that can be part of phenytoin toxicity. What I would think about predominantly is eye movement abnormalities and a depressed level of consciousness, right? That sort of is how I would, if they don't have those 2 things, it's probably not phenytoin toxicity. Long-term use will increase your fracture risk. So you have to screen patients again for step 2 who have been on seizure meds for more than 5 years. They should get a DEXA scan. And then also teratogenic folate disruption neural tube defects. There's sort of the fetal hydantoin syndrome that has a laundry list of things that are associated with it, but I think it's usually fairly obvious that there's maternal phenytoin exposure. Any particular kind of nystagmus? Great question. So the way that you should think about nystagmus is if the eyes always go in one direction, right? So if they always beat left, and it's going to get worse if I look to the left, and if I look to the right, they still may beat left. That's coming from ears, right? That's peripheral. If I look left and my eyes beat left, and I look right and my eyes beat right, that's central. So it's bidirectional nystagmus. Phenytoin causes central nystagmus, which can be bidirectional horizontal, can be rotatory, can be vertical, but it should be a type of nystagmus that makes you think it's coming from the brain. I know nystagmus is confusing, but basically horizontal, unidirectional is peripheral, anything else is central. Zero order kinetics. So that means that no matter how much is in my body, it is eliminated at a constant rate. So if I have 10 phenytoins in my body, over an hour, I will eliminate 2. In hour 2, I will eliminate 2. Hour 3, I will eliminate 2, right? I'm just choosing a constant rate. Versus if you think about something that's at first order kinetics, that's when you get into the half-life world, right? So if I have 10 whatever in my body that obeys first order kinetics, at hour 2, I'll start with 5 and then 2.5, right? And then 1.25. So if someone has high levels of toxicity, it takes them a long time to clear their phenytoin. And then again, more so for real life, not as much for tests, you're going to see that it's highly protein bound, but how much albumin someone has in their body is sort of a reflective state of how much protein they have. And that can really matter actually for phenytoin toxicity levels, drug monitoring. So worth thinking about those things when you read them. All right. Any questions on phenytoin? I think
what are two broad categories of pathology where you might have like a low albumin in the blood? Does anyone know? Yeah, liver. Yeah, liver produces albumin. And then what if you lose too much of it? Where might you lose it into? Yeah. So kidney disease, chronic kidney disease, absolutely. And then the edema comes from the low osmotic pressure from the low albumin. Exactly.
Okay. I'll add the third more rare, right? So the conditions that cause low albumin. So the OCs, right? So you have nephrosis, so nephrotic syndrome, cirrhosis, so liver dysfunction, and then gastrosis. You can have protein losing enteropathies, and you can also have low albumin for that reason. So yeah, great things to think about. I think the only other thing, if you're someone who's like, I want every fact about everything known to man, and I want you to, there is other drugs that can cause gingival hyperplasia. I've only seen one other class of medicine tested, right? It's almost always phenytoin, but there is another class of medicines that I've seen questions on that can cause gingival hyperplasia. Yeah, great, Elizabeth. Awesome. Calcium channel blockers, right? So sort of classic, I think verapamil and diltiazem more so than things like amlodipine, nifedipine, nicardipine. Great. It's impressive. I feel like people don't normally know that one. Okay, my favorite thing, my thing that I was the most excited to talk about tonight, management of Parkinson's, right? So Parkinson's disease is a failure of what I have on the slide right now, right? So I have loss of dopamine producing neurons in the substantia nigra. And because dopamine is so important for how the basal ganglia moves, I think there's another video that I've done in the past on the pathology, the physiology, if you will, of the basal ganglia. But basically, it just augments movement through the direct pathway, and it suppresses the loss of movement through the indirect pathway. So dopamine is pro-movement, and losing it makes people slow. Cardinal symptoms of Parkinson's disease are a resting tremor, right? So kind of classically described as a pill rolling, right? But a low tremor looks like this. Rigidity or difficulty passively moving the limbs. Bradykinesia or slow movements, right? So if I can tap my fingers that fast, someone with Parkinson's disease can't move that quickly. And then postural instability. If I pushed someone with Parkinson's disease, they would have to take several steps and they would potentially fall over, versus most of us can sort of right ourselves with one step. Lots of other features. There's the masked facies, there's the stooped posture, there's the decreased arm swing. Lots of things to think about with Parkinson's. But 4 cardinal features, and all of it has to go with loss of dopamine. So how do we fix it? Right, lots of targets for us. And so this is where I think we should focus on mechanism of action. We'll briefly review biochemistry. So dopamine is produced from L-DOPA, which is produced from tyrosine. And why can't I just give someone dopamine, right? Why can't I, Daniel, if I gave you dopamine, what would happen?
Well, it'd probably give me some calories, but that's about it, right? My stomach would burn it all up.
So you would absorb dopamine, but right, we have dopamine receptors all throughout our body. So I don't think that it would get up to the basal ganglia, right? It would,
the blood-brain barrier.
People who just take dopamine, right, we can use dopamine as a pressor. And sort of it's the classic ones like fendolipam for people who have renal perfusion. It's not in real life, but that's on tests.
Oh, yeah.
So it can cause peripheral it has peripheral vasoactivity at the D1 and the D2 receptor, and it makes people so nauseated. So dopamine really, really, really makes people miserable if you give it to them in their stomach. So we started giving people L-Dopa, right, or levodopa, which is a precursor, in the hopes that that gets absorbed, crosses the blood-brain barrier, and then becomes dopamine in the brain and does all the great things. Yeah, and then everyone else in the chat mentioned like the most important thing, which is dopamine itself isn't going to cross the blood-brain barrier, and it's going to do all those bad things peripherally. Okay, so if I give someone a whole bunch of L-Dopa, how do I make sure that it doesn't become dopamine in the body, right? Because what would stop this L-Dopa to dopamine in the body? Perfect, Dev. Yeah, and Joseph, awesome. Carbidopa, right? So this arrow that I have down here is sort of what I'll talk to you about, the peripheral conversion of L-Dopa to dopamine. And carbidopa is going to block that. It's going to allow more L-Dopa to remain unconverted and cross the blood-brain barrier. Does anyone know the brand name for levodopa carbidopa? Carbidopa. It's okay if you don't. You're never going to be tested on this. You're going to see patients on it. So it's Sinemet, Sinemet, and the name of that medicine is from the Latin sin emesis, without emesis, right? So the addition of carbidopa to levodopa prevents the peripheral conversion, which lowers the amount of emesis. So you can give people extra carbidopa if they're getting too much vomiting, you know what I mean, if they have too much GI distress from their levodopa. I just think that's cool. It's a cool drug name, actually makes sense. So, okay, great. That is the cornerstone of Parkinson's management. If you're gonna know one medicine in whatever field you go into for Parkinson's disease, levodopa carbidopa is sort of the one that everyone gets. But you're like, hey, Michael, there's a lot more drugs on the drug list that I have to know and I get tested on. So I'm now going to move into this box, right? So this is dopamine within the brain. And I can target a few things here. Dopamine is broken down in the brain by catecholamine O-methyltransferase and monoamine oxidase inhibitor, like monoamine oxidase type B. So I could improve the availability of this dopamine, right, by driving more L-Dopa into the brain. I also could block its breakdown. And I want you to just think about this, right? I think this makes conceptual sense. The drugs that are COMT inhibitors, did anyone? Yeah, so entacapone and tolcapone. I think you would be really well served just to remember both of them and that they both inhibit COMT. When you look at more details, it's going to tell you that entacapone is more peripheral and less central, and tolcapone is more central and less peripheral. Tolcapone also has liver toxicity. Yeah, people are putting lots of the sort of common mnemonics. So enta can't enter, so it's more peripheral. And then tolcapone does the total, right? So it does the inside, and then it's toxic to the liver. However you choose to remember it. But if it's overwhelming, just remember the mechanism, because I think that's how you're going to be tested more often. MAO-B inhibitors, sort of two that I think of. Selegiline, great. And then the one that shares the end of the word, rasagiline. Perfect. Awesome, everyone. Yeah, great. So those are all going to increase my dopamine availability. And then let's say that I've just given up on trying to help my own endogenous dopamine, right? I don't even have enough neurons anymore that if I give them L-Dopa, they can make dopamine. And so then there's nothing here for me to produce, right? I can circumvent this whole system and I can just give someone a direct agonist to the dopamine receptor, right? I can give them a drug that's just going to skip all of their normal body physiology. Joseph, amantadine is great. Amantadine is kind of a weird mechanism. It's like very hand wavy, like it releases more dopamine from nerve terminals. Yes, it can totally work. But if I'm talking about the direct dopamine agonists, which drugs am I thinking of? So I see ergot, I see cabergoline, bromocriptine, great. Yeah, so the three that I think about, and Dev, I'll talk about cabergoline, right? So the three that I really think about are bromocriptine, pramipexole, awesome Auburn, and ropinirole is also a direct dopamine agonist. The one that's used for Parkinson's is pramipexole, right? That's sort of the one that's used most. You all don't have to know that, but just again, from me, that's the one that I see the most. Kind of interesting side effects of these drugs. I'll move into the next slide, but any questions on these meds before I move on? And then I'll talk a little bit about side effects on the next one and why. Someone had mentioned ergots. So I believe, right, bromocriptine is an ergot derivative, which is not used as often, has higher toxicity profiles than the non-ergot. Jasmine, I'm going to ask you to clarify what a DDRI is. That doesn't stick out to me, but as soon as you explain it, I may know exactly what it is. And I will move on to the next slide in the interim. Okay, I like this slide. I think that this is something where the primary sort of physiology is really helpful to think about. So there's 4 dopamine pathways in the brain, right? There's the mesolimbic, right? So from the middle to the limbic system, the mesocortical from the middle to the cortex, the nigrostriatal from the substantia nigra to the striatum, and then the tuberoinfundibular, so the infundibulum of the pituitary. And then you have lots of disease processes that, dopa decarboxylase reuptake inhibitor. I don't know. I don't know that you're going to be tested on those. I don't know that they're clinically used that often, but I'm sure they exist. So in Parkinson's disease, right, our sort of main problem is that we have not enough dopamine in the nigrostriatal pathway. And I'm going to contrast that to schizophrenia, where we have too much dopamine going in the mesolimbic pathway, causing hallucinations and things like that. In schizophrenia, we also sort of have a flat affect and negative symptoms that come from dopamine dysfunction in the mesocortical pathway. When I treat Parkinson's disease and I give them dopamine, right, I increase dopamine everywhere. So it sort of balances the effect at the nigrostriatal, which is great. It helps people move more. But I run the risk of causing hallucinations as a side effect, right? I can make someone look like they have schizophrenia. Doesn't necessarily help people think better, right? Doesn't necessarily increase in the tuberoinfundibular, doesn't do anything. So then if I talk about the primary treatment of schizophrenia, which is blocking dopamine, right? So atypical antipsychotics, and I give them atypical antipsychotics, I think that's great, right? It's going to balance out, it's going to help their hallucinations. Doesn't necessarily help their flat affect, right? So that's sort of, their symptoms are usually refractory to treatment. But if I block the nigrostriatal, then that looks just, so that's why I can cause Parkinsonism, right? And if I block the tuberoinfundibular pathway, dopamine is inhibitory on the release of prolactin. So if I block dopamine, then I'm not inhibiting prolactin release, which means there's too much prolactin. So I can get lactation, hyperprolactinemia, low libido, things like that. If your mind is not twisted, someone asked earlier about cabergoline. If I have a tumor of the pituitary that's making too much prolactin, and I want that to slow down, remember dopamine turns prolactin off. Cabergoline is the agent of choice for pituitary adenoma. This may be confusing, but I actually think it's really nice, right? So this is why these drugs cause the side effects that they do. I don't really need you to memorize a list of side effects with Parkinson's meds. Just know that if you overdose people on dopamine therapies, then they're going to look like they have schizophrenia. They're going to hallucinate. The only other thing that I think is just interesting and that you may read is, remember, dopamine is also sort of in the addiction pathway. So people who are on dopamine agonists can get impulse control disorders. They can get pathologic gambling, have a higher risk of having addictions. Okay, we'll breathe and pause from Parkinson's. And I'll move on to headaches. Questions about Parkinson's? The only 2 other drugs you'll see trihexyphenidyl and benztropine for tremor. Those are anticholinergic drugs. And what I would tell you is that there's a balance in your brain between dopamine and acetylcholine normally. And people who have Parkinson's, right, they have no dopamine and they have too much acetylcholine, and that can make them sort of tremulous. Again, not if you look at a basal ganglia, researchers, they're not going to agree with how I phrase this, but then giving them an anticholinergic can balance the two again, and it can help reduce tremor, but not necessarily a treatment for Parkinson's, if you will. Okay, I'll be more brief with headache. Headache is all about classifying the headache, right? So if you go back to my shortcuts, it's all about what is the indication. So once you've proven someone that has a migraine, right? So you can use your pound mnemonic, right? So pulsatile. I don't know the mnemonic. I don't use the mnemonic. I see lots of migraines, right? So I normally think of one-sided, pulsatile. Oh, I think it's onset over a day. Sometimes can have neurologic symptoms, and it can be disabling. For most people, you can get away with NSAIDs or acetaminophen, right? Caffeine can also be helpful for most people. And then for some people, you have to escalate. And so you give them a triptan. Does anyone know the mechanism or sort of the neurotransmitter that I act on with a triptan? Awesome. Yeah, serotonin. So these are serotonergic drugs that are supposed to vasoconstrict. And so if I vasoconstrict in the brain, that can surely help someone's migraine. But where do I worry about vasoconstricting? So who can't I give these medicines to? Elizabeth Good thought, I don't necessarily worry about stroke. It makes sense, right? But not necessarily. So these medicines are contraindicated in people who have coronary artery disease. Yeah, so perfect, Cynthia. Vasospastic angina, coronary artery disease. I worry about causing too much vasoconstriction around the heart and causing an MI. Perfect. That's how you treat a migraine, right? There's lots of other drugs, right? There's sort of, when you work in your ED, that we throw all kinds of things at people with migraines. Some people respond to certain meds, but for you all, right, think triptans. And then the ergot alkaloids are not really commonly used anymore, but sometimes are. They have a more severe coronary artery disease risk, so that's why they're not used. You prophylax people with migraines who have so many headaches that it's worth taking a medicine every day to reduce the number or frequency of their headaches. And there's a laundry list of prophylactic agents. When you don't have to know them as much for step one. For step two, you always pick based on the side effect of the med and what the patient may have, right? So if someone has a migraine and I want to give them a prophylactic, right, I can choose valproic acid, I can choose propranolol, I can choose topiramate, I can choose all kinds of things. They're going to have some other condition that's going to make those meds wrong, right? They're going to give you a history of kidney stones, so you don't use topiramate. They're going to give you fear of weight gain, so don't use valproic acid. They're going to give you a history of asthma, so don't use propranolol. I think it's less important for you to sort of know every single agent that can be used prophylactically. Most meds that I think you see on those questions are going to be acceptable prophylactics for migraines. I will add recently, and I don't know when these will move into the testing world, in like the last couple of years, they've developed perfect Auburn, CGRP agents, right? So these are monoclonal antibodies to calcitonin gene-related peptide that can be used both as an abortive and a prophylactic for migraines. Irenyumab is sort of like but I wouldn't memorize all those. I think you're, again, more likely just to be tested on whether or not CGRP is a player, and yes, it is. Thank you, Joseph. I'm not a mnemonic person, so I know they exist and I know the features of them, but I almost never can recreate the mnemonics. Cluster headaches. So these are sort of unilateral, shorter, right? So I tend to think of symptoms for minutes. They happen in clusters, so people will have them for 4 or 5 days at a time, every March or something like that. And they cause, what else do they cause? So what else helps you pick a cluster? What other sign of symptoms? So stabbing pain, right? So people definitely cause it a stabbing pain quality more so than a migraine, which is pulsatile or throbbing. Yeah, lacrimation, perfect, right? So we get autonomic features. So their nose will run, their eyes will water. They'll have a pupillary constriction on that side. Yeah, perfect. So we'll have some sort of dysautonomia or autonomic feature associated with the headache. The treatment of choice on tests is 100% inhaled oxygen. Can abort a cluster headache. You also can use triptans for these people. And then less commonly tested, but still important to know the only agent really indicated for prophylaxis is verapamil. There's non-medication prophylaxis for all this, so you can do Botox and all kinds of stuff for people, but and then tension headaches are right are classic, like, oh, I just sat through Michael talking for a while and now I have a headache, right? Band-like headache around the temple, usually not high intensity, and you can treat that with NSAIDs and acetaminophen. My little secondary thing, if you can see it kind of slid very close to the bottom, I was like, maybe I should talk about that. So secondary headache, right? So headaches from brain tumors, headaches from, hemorrhage in the brain, right? You treat the primary pathology. And then I'll just mention for brain tumors, what would you use if someone had lots of swelling in their head from a brain tumor and it was causing them a headache? Acetazolamide. Oh, great. Perfect. So not necessarily for brain swelling. You're giving me great answers. Acetazolamide is the agent of choice for idiopathic intracranial hypertension. So great drug for that headache disorder that I totally should have on the slide. Mannitol is used for someone who's like herniating. And I'm like, oh man, like they are herniating and I need to relieve that swelling right out of the gate. If someone just has edema in their brain and it's causing them to have a headache, you can just give them steroids. So steroids are great to relieve headaches from edema.
I think it's important to distinguish here between stuff where like the entire brain is swollen versus the area around the tumor is swollen. Like the area around the tumor is swollen because of inflammation, where like some of the things like mannitol, that may be more of a hemodynamic correction.
Yeah, no, and mannitol is like you're in the ICU and like your brain is like trying to squeeze through your foramen magnum, and I'm emergently giving you mannitol to try and prevent that from happening. But if you're just like in the outpatient setting and you have a brain tumor and a headache, we're going to give you steroids.
And does anyone know like the last resort treatment for if you think someone's about to herniate and mannitol isn't working, acetazolamide isn't working? Anyone know what the last resort is? Hypertonic, that's good. That's good. It's actually not a medication. You do craniectomy. You take a big window out of the skull to allow the brain to kind of spill out. And a lot of times you can take the bone and preserve it, and you just suture the skin right over the top. It's pretty crazy to see. And then once the swelling has gone down, boring. Once the swelling has gone down, you can then put the skull back on. Okay.
Elizabeth, are you bored by intracranial pressure management, or are you referring to a borehole? Yeah, a burr-hole, B-U-R-R, perfect. I think that was a great pun either way.
Well, they start off with burr holes around the perimeter, and then they saw, right? You can't just burr a hole like a single hole, and then it like, not enough brain will be relieved, but that's a good thought.
It is a good thought. And it's also why babies really don't have herniation from high ICP, which they have all the time because their fontanelles are open. So you'll just see their little fontanelle bulge and they get like a little pressure window. But adults, we don't have that. Our skulls are fused. That's why we have to take a piece off. Yeah. Super quickly, I want to make sure that we spend time, right? But I just want to talk about sleep. Again, your first line treatment for sleep is always sleep hygiene. And so you can sort of look that up, right? But it's no screens before bed, commonplace, right? So doing all the right things. All of you know the Z drugs, right? So Zolpidem or Ambien, Zalopon and Zopiclone. They're less sedating than benzos. They act on the same receptor at a different site. That's sort of the important thing to think about. I listed some other agents here. Ramelteon acts like melatonin, so acts at the suprachiasmatic nucleus. And melatonin is the safest sleep agent, especially in geriatric populations. So has a little bit of a next day sedation risk, but virtually really no other contraindication. So Ramelteon is sort of the safest choice. Trazodone is the most commonly used. I use that medicine all of the time. Better sleep agent than is an antidepressant. Suvorexin is an orexin antagonist. And then again, sort of things that people do, but is not necessarily textbook correct is things like benzos. Are docs able to talk about CBD? I think it depends on where you live. I know that in California, right, it's legal, so I can talk to patients about that all the time at UCSF. But then when I practice at the VA, the national, right, owned hospital, and even if patients take CBD at home, I cannot let them take it in the hospital. So why would one use Ramelteon over melatonin? That is a great question, Auburn. I have never in my life used it for Meltion. I just use melatonin. But there may be a reason. Super quickly, I'll just touch on motor neuron disease. So ALS, or again, sort of more broadly motor neuron disease, we can't cure it. The medicine you need to know is Riluzole. Riluzole slows disease progression, really only by about 3 months, through reduction of glutamate, excitotoxicity, I apologize. There's another approved treatment, Darivone, but I don't think that any of you are ever going to be tested on that. If you are, that's sort of one of the ones where you're like, great, good to know. I'm not going to be a neurologist. I don't need to know the last line agent for ALS. And then palliative care actually improves survival in ALS. I think that's an important thing that I just want people to know. So engaging people in palliative care makes people live longer when they have ALS. Spinal muscular atrophy, right? So sort of the failure of the survival motor neuron gene, also called Worden-Hopkins disease. Right? So floppy baby syndrome is sort of the other, was cured in 2016. So there's now gene therapies, right? So I think the one that was in 2016 was nusinersen, and now there's ones that I can't pronounce that may be curative. We don't know. It's still an early drug. The drugs cost like $2 million per dose. So it's kind of a big health equity thing, but exciting. I think that's a big change in our careers in our lifetime. That's a disorder that used to be universally fatal and is now having kids live past 1 year old. So that was cool to mention. Anything, Daniel, for ALS, or these are fairly straightforward?
No, I thought it was interesting you saying that palliative care increases life expectancy. I think that there are a lot of people who may intuit like the opposite.
Yeah, I think so.
Or that they're scared to call palliative care, right?
Yeah, all of us want to, I just, as someone who's a neurologist and who's going into palliative care, right, from neurology and wants to do hospice for people with neurologic disorders, that's why I make this plug. Addressing a person's entire existence, their spiritual, their psychological well-being often makes them live better lives. And in this instance for ALS, they live longer lives by a little bit. Okay, dementia, so sort of on the similar train of things that we can't cure, but we can slow progression. I'll talk predominantly about Alzheimer's disease, not the other dementia types. So we can't cure it. There are medicines that slow progression. Again, when I tell patients they have dementia, I'd like to start them on a medicine. I tell them that the trajectory is this, and that giving them the medicine may make their trajectory this, that I don't expect them to have day-to-day improvements in their memory, but they have lower rates of institutionalization at certain years, XYZ, you get the point. They're all acetylcholinesterase inhibitors, and then there's memantine. So this is where I want to sort of just everyone to just channel all of your knowledge about acetylcholine, where it is, what it does, it's everywhere. And then we can think about why certain side effects happen from acetylcholine blocking drugs and acetylcholine promoting drugs, right? So if I gave someone an anti-cholinergic drug, right, I dry them out. Cholinergic is sort of the wet and the sticky, right? If I have cholinergic toxicity, then I have diarrhea and lacrimation and all kinds of stuff. These drugs are at so low doses that I'm not really doing that. But if I'm giving someone an acetylcholinesterase inhibitor, do you think this causes constipation or diarrhea? Increasing the amount of acetylcholine available. 50-50. So diarrhea, right? So sort of GI distress is the side effect that you'll see here. But this can cause, and I think that should conceptually make sense to you when you think, okay, more acetylcholine, right, helps circuitry neuronally, but it also can cause a little bit of more acetylcholine in the gut. Most commonly used is donepezil, then rivastigmine because it comes in patches, and then galantamine I've never used. Memantine is an NMDA antagonist, right? So ketamine is also an NMDA antagonist. And the side effects of memantine are things like hallucinations, confusion, disorientation, right? Exact same things that you would expect in someone who is recreationally or therapeutically taking ketamine. Just a little fact at the bottom there, acetylcholine comes from the basal nucleus of Meinert, which is also sometimes just called the nucleus basalis. And I only have a few more slides where I really just am going to go on such a little acetylcholine kick here for a moment. We'll talk about myasthenia gravis. So remember, it's autoimmune, and I think that's important when we think about, just again, conceptually, right? I want all of you to be able to explain medicine to people who don't know medicine. That's your goal with patient care, right? You have a disease that is antibodies to the receptor that makes your muscles work. So I want to give you medicines that help your muscles work better, and I want to give you medicines that stop those antibodies from happening, right? I think that if you know myasthenia to that level, you can get a lot of questions correct. Pyridostigmine is an acetylcholinesterase inhibitor that increases the availability of acetylcholine for those few remaining receptors at the neuromuscular junction. It is symptomatic treatment, right? So people will feel less fatigued, stronger after the administration of pyridostigmine. There's another acetylcholinesterase inhibitor that you're often tested as part of the diagnosis for myasthenia gravis that's super short acting, and you give it to people and they should get better right after they get it, and that is diagnostic. Do we remember the name of that drug? So neostigmine is another one. Yeah, perfect. Is it edrophonium? So edrophonium is a super short acting. You'll read it as the tensilon test, right? So you can sort of, if you think someone has myasthenia, you give them edrophonium. It's like rapid onset and comes off in like 10 minutes. They should get better, which used to be diagnostic. We use different things now. People mentioned other acetylcholinesterase inhibitors. Those are really used in other conditions. So physostigmine is the one that freely crosses the blood-brain barrier. So if I give that to someone, it sort of helps augment acetylcholine in the CNS. I really only use that in organophosphate or sort of central anticholinergic syndromes where I need more acetylcholine. But in myasthenia, I just need it peripherally. So I don't need it to cross the blood-brain barrier. And it has to do with I think it's a quaternary, I don't know. I have the luxury of forgetting a lot of the biochemistry now as a resident. All patients with myasthenia benefit from a thymectomy. That's where the antibodies come from. So look at their thymus. In step 2, if you diagnose someone with a myasthenia, you need to CT scan their chest to look for a thymoma. And then most need immunosuppression, right? So again, all the drugs that knock people's immune systems out. So steroids, mycophenolate, things like that. Well, acetylcholine, pro-muscle, pro-brain.
Yeah, well, I mean, there are different receptors, right? So there's a neuromuscular receptor, and then there are 3 other receptors. Does anyone know which ones they are? I hope this is anyone know what the receptors are and where they're located in the body?
So nicotinic, so that's going to be our muscular one. And then we have muscarinic receptors, and that's, I think, what Daniel's alluding to with the 3 subtypes.
Yeah.
M1, 2, and 3, I'm seeing sweat glands, which the way that I like to classify these for people is like, I don't know, Daniel, how do you do it? Right? Like M1, I think of one thing, M2, I think of one thing, and then M3 is everything else.
Yeah, so M1 is up here, right? M1's up in the brain, M2 is in the heart, and then M3 is everywhere else, right? And then there's the nicotinic muscular. So if we're thinking about different pathologies like myasthenia gravis, this is a problem with the nicotinic muscular receptor. And then if we think about the drugs that we may use, we then have to think about side effects would be too much acetylcholine in some of the other receptors as well.
Yeah.
And then vice versa, too little, then you have too little. So, Mad Hatter, for example, as one of the symptoms of acetylcholine toxicity, like too much in the brain, right?
Yeah.
And then cardiac. So.
And then again, I think that I'm so glad you brought that up because dementia, right? So let's say I want someone on donepezil to increase acetylcholine at the M1 receptor. I also increase it at the M2 receptor, so these can cause bradycardia. I also increase it at the M3 receptors, they can cause diarrhea and GI distress, right? So that's why I'm saying, rather than memorizing a list of side effects for these meds, just being like, great, acetylcholine should do all of these things, you're gonna be really, really well served for more types of questions. Okay, I think last slide for me, maybe a little bit of a different format, and just for some fun to mix it up. First, I'll ask someone, what is this diagnosis? This person is oh, you guys don't even need a one-liner. Everyone's got it. So yeah, this is a subarachnoid hemorrhage. You can see sort of the blood here. So this is, I will call this the pons. And then this is a sort of a, you can see this bright white blood here, and it's sort of collecting here as well. So this is a subarachnoid hemorrhage. Daniel, have you taken care of any of these in your clerkships yet?
The only time I kind of did was I was in neurosurgery for about a month, and we got a whole bunch of consults for subarachnoid hemorrhages, and no surgical indication, no surgical indication. So I know I haven't taken care of it. I've had a bunch of epidurals and subdurals though.
Those have huge surgical indications, but these don't have surgery. So these are more in my court, right? So non-surgical brain disorders. This is blood that's leaking from a vessel into the brain. So do I want these people's blood pressure high or low? Yeah, perfect. Jasmine Deep. Yeah, so I want their blood pressure low. So this person is not going to get surgery. They need blood pressure reduction. They may need a drain, right? So that's where neurosurgery gets involved here, but that's different. And then someone mentioned nimodipine. Awesome. So blood is irritating, right? So if blood is somewhere in the body that it's not supposed to be in, your stomach, anywhere, it irritates that tissue, especially the brain. If blood irritates the vessels that run through the subarachnoid space, they can spasm and close off. Nimodipine is the agent of choice for preventing vasospasm after a subarachnoid hemorrhage. There are 3 N calcium channel blockers that all have separate little like specific step 1 facts. So I always like to just name them, right? So nimodipine for subarachnoid hemorrhage, nifedipine for hypertension in pregnancy, nicardipine for hypertensive emergency. And that's because it being given in a drip. But those are the 3: nimodipine for subarachnoid, nifedipine for pregnancy, nicardipine. Okay, I will gladly answer questions in the chat. Daniel's going to talk about pain. We have a few more slides just for people planning. I know we always say an hour, probably about 10-ish more minutes of slides.
Yeah, hi. Okay, so talking about pain here, we have different classifications of pain. So nociceptive pain, meaning that the receptors in the tissues are picking up some sort of irritant, and they're transmitting it to the brain to let you know something, right? So nociceptive pain would be an adaptive pain, as in I have a broken bone, and evolutionarily, I want to know that, right? So that can be somatically to the tissues or viscerally to the organs, right? And then there's neuropathic pain, and neuropathic pain is maladaptive pain, right? So it's not telling you something that you need to know. It's a symptom of disease of the nerve itself. The classic example of this would be diabetic neuropathy, right? The microvascular changes and damage that causes ischemia to those longest nerves, the ones that go all the way down to your feet, that damage makes the nerves fire abnormally, and then that gives you a burning pain that isn't telling you something that you need to know, essentially. So that's why I tend to classify these into 2 different categories, because they also get treated differently, right? The best treatment for nociceptive pain due to an infection is not a pain medication, it's an antibiotic, for example, right? But the best medication for neuropathic pain would be something that would actually modulate the nerve function itself, right? So I already mentioned diabetic neuropathy. I also wanted to talk about arthritis. So how would you calculate, or how would you classify arthritic pain? Do you think that that's more of a nociceptive or neuropathic pain? Does anyone know? Yes, it's more of a nociceptive pain because the nerve fibers in the synovium lining the joint, they're getting irritated for some reason, and they are letting you know, hey, this joint isn't working properly, right? That could be inflammatory, could be infectious, could be osteoarthritic, it could be any sort of cause that would cause a nociceptive pain. And from the tissue damage, you end up with all the inflammatory markers, right? And then that's when you end up using drugs that try to decrease the inflammatory markers, like NSAIDs, for example. And then appendicitis is an interesting case of, so first off, would it be nociceptive or neuropathic pain overall? I'm just gonna assume that one of these is actually, it's nociceptive pain, right? But appendicitis moves. And I was wondering if anyone knows, maybe based on this schematic that we have written up here, why do you think that the pain from appendicitis ends up moving? Can anyone justify that based on the different kinds of pain here? It may be a long bit to type. Okay, yeah, so a referred pain, meaning it starts off viscerally, right? So it starts off as a visceral referred pain to the umbilicus, right? But the appendix isn't actually there, right? So first off, you get the pain from the appendix itself, that visceral pain, innervated by around the T10 area, right? But then why does it end up moving? It ends up moving because it starts to irritate the actual somatic abdominal wall, right? Okay.
Cool. I just had appendicitis, so I had. I know McBurney point tenderness everywhere.
Yeah. Get off of there. The cat just jumped up onto my desk. Yeah, so acetaminophen. Mechanism of action, it's one of the COX inhibitors. Big high yield for the boards is like, what are the overdose symptoms and what is the treatment? ALF. What do these?
Acute liver failure would be my.
Oh, acute liver failure. Okay, yeah, exactly. Yes. So you get, you can get jaundice. You can get increase in LFTs. Okay, and then what's the treatment? Good. Yeah, N-acetylcysteine, right? Because it's due to glutathione depletion. Okay. And yeah, importantly, like Michael said before, maybe it's more of like a second or a step 2 question, but determining, okay, this person has pain, which drug do you give them? In the step 1 context, it could be that someone has pain, the doctor chose this medication, they may ask you why, right? So maybe this is a 88-year-old male here for, let's see, a cardiac arrest, and resuscitated after only like a minute or so, and then he's in the hospital. Maybe you're trying to like treat his his arthritic pain, or maybe he develops gout or something like that, right? You wouldn't want to give a typical NSAID because of the risk of ischemic gastritis, right? You wouldn't want to increase the risk of stomach ulcers further, for example. So that's why you wouldn't choose an NSAID. That's why you maybe would go towards the acetaminophen route, right? Okay. Alcohol, and does that overdose, that decrease the risk of acetaminophen toxicity? Does alcohol decrease the risk of acetaminophen toxicity? Oh, increases. Yeah, absolutely, right? Anything that damages the liver if it's compounded, yes.
Normal people can get more up to 4 grams of acetaminophen in one day. People without liver dysfunction, people who have liver dysfunction can get a max of 2 grams. So if someone has concurrent hepatotoxicity, then you limit the amount of acetaminophen because they are more susceptible to that kind of injury. Yep. That's because, remember, it needs to be conjugated, right? So you need sort of normal liver function, or else you develop the toxic metabolites and XYZ.
Okay, good. Okay, so then the other one is aspirin. More likely you end up with patients on a low-dose aspirin to inhibit platelet aggregation, but it can also be used for pain. It's another COX inhibitor. What would be the difference between aspirin and maybe like the NSAIDs or acetaminophen in terms of? There we go. Yeah, good. So it's first off, it's a permanent COX inhibitor, right? So there really is no reversal for it besides just getting new platelets, whether or not that you give that time, or if it's very emergent, you can end up giving like platelets as a transfusion as well, right? And then race and accepting race syndrome, right? Well, yeah, there we go. So which demographic should never get it? Kids, right? Because they can develop Rey syndrome, except in what disease is the exception? And then I see someone here, Kawasaki disease, absolutely. Platelets and after 10. Okay. And then NSAIDs. Again, we know that the mechanism of action of NSAIDs, COX inhibition. In which diseases should this be avoided? And that may lead you towards thinking, okay, what are some of the side effects of NSAIDs, and what may they exacerbate? So I don't know about Michael. You may correct me if I'm wrong. I don't know about GERD, but I know peptic ulcer disease is something that you want to avoid, right? Is GERD another one?
Not necessarily, but I think that.
Yeah. Okay, so I see peptic, yeah, exactly, renal disease, right? Can someone describe like the mechanism for why you may want to avoid NSAIDs in renal disease? Okay. Yeah, because it has to do with the vascular regulation of the glomerulus, right? So you can cause acute ischemia because the prostaglandins vasodilate the afferent arteriole to the glomerulus. So if someone already has poorly functioning glomeruli, you then don't want to further decrease their kidney function. Okay. And then celecoxib is the selective COX-2 inhibitor. That avoids some of those other bad effects, like the kidney and the ulcers. The major side effects would be thrombosis. So you don't want to give this to somebody with a history of DVTs, for example. Okay. Okay, so then the local anesthetics. So this is kind of, I guess, an overlap between the nociceptive and neuropathic pain. They're the peripheral nerves that we want to turn off, essentially. So whether that someone's getting a procedure and you don't want to have to fully sedate them, maybe someone's getting a root canal or something like that, you want to just turn the nerves off in certain locations. So does anyone know what the mechanism of action is for these local anesthetics, such as benzocaine, lidocaine? Yeah, blocking sodium channels. And as you know, the sodium channels are important for the action potential. So here's another thing. You know, if you're trying to anesthetize tissue that is inflamed and infected, local anesthetics don't work as well. And that's because when they're in an acidic condition, they are unable to like penetrate into the tissues, specifically into the lipophilic nerves, right? Because when they're in an acidic tissue, these drugs are weak bases. So they go from a base B to a base H plus, right? So they develop a charge, and that doesn't allow them to get into those fatty nerve cells, right? Why inject it with epinephrine? Epinephrine is a vasoconstrictor, right? So you want to try and decrease the amount of blood draw away from the target site that you are trying to anesthetize, right? Yeah, localization, absolutely. Vasoconstriction causes the benzocaine to not go as far, right? And what if you accidentally inject a whole bunch of lidocaine? You're trying to maybe anesthetize some region, and you accidentally inject into the subclavian vein or something like that. Yeah, absolutely, an arrhythmia, right? So if it goes directly into the blood supply, it can cause cardiac issues. Okay. So now here's the real, the heavy hitters in pain, right? The opiates. So morphine, hydromorphone, fentanyl. So does anyone know what receptors they work on? Yeah, the mu receptor, absolutely. Based on what you know about action potentials, right? what sorts of ion channels do these mu receptors activate or open or anything like that? How do they affect the ion channels? Yeah, so the mu receptor is the major pain receptor, right? Yeah, so one of them is the postsynaptic potassium channel, right? So then that causes potassium to flow out of the nerve, right, and hyperpolarizes the nerve, right? So positive potassium flows out, the nerve gets more negative, and then it's less likely to fire, right? And then absolutely closes the presynaptic calcium channels, right? So in the presynaptic nerve, it closes the calcium channel, doesn't allow the neurotransmitter to be released. In the postsynaptic nerve, it opens the potassium channel, causes positive charge to flow out of the nerve, hyperpolarizes it negative to not allow it to fire. So it works at two major sites, right? So there are major side effects. What is by far the most I guess what you could say the most common side effect of opiates? Yeah, so constipation, absolutely. So whenever we have patients on opiates in the hospital, we try to give them a bowel regimen, like a stool softener like Docusate, or especially stimulant like Senna, right? The opiates decrease gut motility, causing hypotension, and meiosis, absolutely. Yeah, contraindicated in pancreatitis due to sphincter voti spasm, absolutely. Respiratory failure, yeah, it decreases respiratory drive. So which ones of these opiates need an ECG before you give it? This one may be less known. And then the question you may ask yourself is, why would I need an ECG in the first place? Pyridine. So what maybe someone has a specific quality of their ECG that puts them at increased risk of torsades. Yeah, methadone, right? So you need to get an ECG to get the corrected QT interval, because methadone, other ones include hydromorphone, for example. Tramadol is another example. Are some of the opiates that can prolong the QT interval, right? So management of an overdose. So as someone said, respiratory depression, absolutely is one of the side effects of an overdose. Mydriasis, yeah, naloxone, absolutely. That's a mu antagonist, right? So here's kind of an odd question. It's so let's say that someone is just loaded up on opiates, and you give them a bunch of methadone, and you take them out like absolutely deplete of opiates, and then they start withdrawing. And can that kill them? Can you die from that sort? So Kim says no. So Mo says no. So the convention, no, but it'll be a rough experience. And the thing is that the conventional wisdom is no, but the rough experience can actually kill you, because these people can get such profound diarrhea and vomiting that they can become incredibly volume deplete, and then that can actually kill them. So you won't end up getting like a seizure, like if you just bounce someone out of being overdosed on benzodiazepines with flumazenil, for example. You won't get a seizure like if someone is withdrawing from alcohol, which is one of the treatments for that is another benzo, right? Benzo withdrawal can be fatal, opiates can be fatal, and absolutely miserable. Yeah, absolutely. All right, so does that make sense? Any questions about opiates?
I will just add that I know that I want to be respectful of everyone's time tonight. Things that I would focus on with opiates, I think Daniel did an awesome job. Yes, everything we've talked about. The relative potency tends to be less frequently tested, right? Fentanyl of the ones on the board is the strongest, but it is important to know how avid they are for the receptors. So some of the opioids, like butanol, for example, are partial agonists at the receptor versus all the ones that we've listed here are full agonists at the receptor. That gets a little more into the management of like long-term opioid use disorder. So methadone is sort of a full agonist, right, but with low potency. And then you have buprenorphine, right, which is a sort of a partial agonist. Those are the two medicines that it can be used for. But just when you're studying, pay attention to how avidly they bind the receptor. And then there's a few that can cause serotonergic effects, and those people like to test on those as well. I think someone mentioned meperidine and tramadol.
Yeah, and they love to ask about if you add on an antidepressant, for example, they're already on tramadol, and then you end up with a serotonin syndrome or something like that. Okay, so now the neuropathic pain management, we have these three major specific classes of drugs that can be used for neuropathic pain. So does anyone know what the mechanism of action of a tricyclic antidepressant? Or if we're trying to be quicker on time, I guess I can just speak through it. It inhibits the serotonin and norepinephrine reuptake. So serotonin and norepinephrine, and that modulates the function of the nerves themselves. The 3 C's of toxicity would be cardiotoxicity, right? Coma and convulsions. Oh, good. Coma and convulsions, so seizures. And then the major reported side effects that people experience are typically the anticholinergic side effects. So as we were talking about acetylcholine before, anticholinergics. So tachycardia, especially if someone's old, maybe someone has prostatic hyperplasia, maybe you can get a urinary retention, for example. So the SNRIs are the vaccines, so venlafaxine, and then oxetine, so duloxetine, and then the nasoprans, so milnacipran, levomilnacipran, and then these are SNRIs, so serotonin norepinephrine reuptake inhibitors. So they can be used for depression, right? And they can be used for depression when you want a little bit of norepinephrine, so a little bit of sympathetic stimulation as well, right? And they can also modulate the functions of nerves. They're more a second line to the tricyclics. And then the major side effects are due to the increased norepinephrine, right? The increased sympathetic stimulation. You can end up with a tachycardia, for example. And then the gabapentinoids include gabapentin and pregabalin. So they inhibit calcium channels. The same way in the presynapse, so they inhibit the release of the neurotransmitter. So then the major side effects of these, by far the most common would be a sedation. Most people end up feeling tired if they're taking gabapentin. Also, they're slow to work. And a lot of these neuropathic pain treatments, it's not like fentanyl. When you get it and then 1 minute later it works. A lot of these take quite a while to ramp up, and they're very much incomplete treatments, right? And there's a whole algorithm for when you start with some and then you can add others and then you can keep moving along based on what people are and aren't responding to.
I treat a ton of neuropathic pain. That's a huge part of some of my clinic patients. I love SNRIs. I think that there's a ton of comorbid psychiatric indications. I mentioned in the chat venlafaxine and duloxetine are sort of the go-to SNRIs for neuropathic pain management. Both also indicated in fibromyalgia if you're ever worried that there's a little bit of an overlay there. TCAs I avoid in the elderly, right, given all of the side effects, right? Anticholinergic. We mentioned earlier cholinergic being great for brain health, anticholinergic terrible for brain health. So I don't love that. Constipation is also super prevalent. So I don't use that as often, but nortriptyline more than amitriptyline. And then the gabapentinoids, gabapentin is super cheap, can be dosed several times per day or just once per day. Can cause sedation, but often I give it at night and people do pretty well with it. And then pregabalin is more expensive, and you don't really have to know that, but that's Lyrica. I'm sure everyone here has seen a Lyrica commercial at some point in their life. They're everywhere. I think we'll skip sedation, and I would encourage you all to just sort of think about on your own time after this, and we can always do another one of these because this was so fun. Things to think about when you're choosing sedation agents in patients. Go over, make sure you know your inhaled anesthetics. Propofol, midazolam is a benzo, how opioids for sedation, and then ketamine has lots of cool properties that I alluded to earlier. So I hope that you enjoyed the time you spent with us. I think that I'd like to just wrap up, and we'll be available for a Q&A. I encourage you to start thinking of questions and putting them in the chat. Things that we offer here at Blueprint Med School Tutors. So Daniel and I both do a ton of one-on-one tutoring, right? So if you're like, I really liked how either of them explained that, and that's kind of nice. I think we both absolutely love to teach. Other things we do for students are sort of help plan out study schedules and timelines. I liked how Daniel mentioned earlier, sort of like the biopsychosocial model approach to being a med student, all the things that go into studying for these exams. We also just do one-time planning sessions, sort of pre-residency counseling. And then again, I mentioned that the Blueprint as just a parent company focuses on sort of being a one-stop shop for anything you may need, sort of no matter what type of learner you are and what you're looking for moving forward. So with that, we'll take a little bit of time, and I will move on to Q&A. There should be a survey that goes into the chat at some point, and Daniel and I would really appreciate if everyone could give us feedback on how we can be more helpful. There was some comments earlier about doing webinars on like drug receptors, which I would be thrilled to do. Big pharmacology dork here, so I think that serves you super well. Great, and I'll make sure I'm not. Auburn mentioned the Beers list, and so the Beers criteria is the list of drugs that you're supposed to be cautious about using in the geriatric population due to side effects and whether or not the risks are going to outweigh the benefits. Does Lyrica have a generic? I think pregabalin's generic, but yeah, I think so. Kim, I'm glad this was helpful. Mohammed, this will be posted on YouTube. The timeline usually varies, but we go through it and it goes on YouTube at some point. Oh, great. The office answered that. Amazing. Great. Any questions? Thank you all for your participation. So give everyone a little bit, and if not, we'll, seeing none, I think we'll say our goodbyes. Daniel, it was super fun. Thanks for being here. Thanks, everyone. And we'll see you next time.
Thank you all very much.